Good evening, everyone. How are you all? All right, guys. So tonight we are going to start with obstetrics. I guess that you guys are doing gynecology right now. So let's start. So for the obstetrics, as you guys remember, I told you in JM 8th edition or even JM 7th edition, there is not much chapters are there for your preparation, but there were some more chapters in JM 6th edition. So we will go through that as well, because that's also a good idea to go through, because there is a lot of important topics out there. So right now in your JM 8th edition, there is only 2 chapters, which is antenatal care and postnatal care. These 2 chapters we will go through from JM 6th. And these are very important chapters, even more important than these 2. Apart from that, you should also read the handbook. In handbook, there is obstetrics and gynae MCQ questions, so you should solve that. If you want a little bit more help, especially if you're looking for a book, then you can go through this Lillian Jones obstetrics book that should be in the PDF that we have shared. And the good one is Kaplan's Tip to CK. We will also follow this most of the time. Solve the Q bank, solve past questions. So that's how you prepare. First, let's start. Now, we will start with some of the high-risk pregnancy cases. So, like a lot of conditions are there which can make a pregnant mother high risk. So, one of them is advanced maternal age. So, advanced maternal age, like who actually fall into that criteria is that women more than 35 years of age, if they get pregnant, they are known as advanced maternal age, and they have a high risk of having a lot of complications. And one of the complications is this chromosomal abnormality, like a trisomy 21, trisomy 18, which is your Down syndrome, Patau syndrome, those syndromes. The Down syndrome is very common. It's one of the commonest genetic abnormality in Australia. So it's very important topic. If you look at here, according to the age, a patient who is 35, the risk is 1 in 365, or the total risk is 1 in 180. So this risk ratio, just remember these 3, 35, 40, and 45. Sometimes it comes in exam. So just remember these 3 ratios, okay? Now, what is aneuploidy? Aneuploidy, this is chromosomal abnormalities in which cells do not contain true complete 23 chromosomal set. So all of you know that human being has 2 pair of chromosomes, like 23 pair of chromosomes, and that's how we make 46 chromosomes. If these 2 complete set of 23 chromosomes are not there, a little bit of abnormality is there. Sometimes 1 chromosome is missing. Sometimes there is an extra chromosome that causes this aneuploidy. The most common aneuploidy is trisomy. Trisomy means there is extra chromosome. Okay, so there is trisomy 21, trisomy 16, trisomy 18. If they ask you what is the most common trisomy in the first trimester pregnancy loss or miscarriages, that's your trisomy 16. And if they ask you what is the most common trisomy at term, that's trisomy 21. And these are all the high-risk obstetrics cases. So elderly primigravida, which is more than 35 years of age, multigravida, like 5th or more than 5 pregnancy, previous history of complicated labor or obstetric history, previous cesarean section, hypertension, chronic kidney disease, high BMI, short stature, diabetes, all of these are high risk category. The very important topic is hypertensive disorders in pregnancy. Okay, so if a pregnant patient develops hypertension during pregnancy, that's something which we will worry about. Now, there are a few terms that you need to remember. One of them is if a patient develops hypertension after 20 weeks of pregnancy, that's what we call as gestational hypertension. Okay? If it is before 20 weeks of pregnancy, then you can't call it as gestational. Most likely that patient had hypertension even before getting pregnant. That means that will fall under essential hypertension. Okay, so more than 20 weeks, patient is hypertensive, that's gestational hypertension. Now, more than 20 weeks, patient hypertensive and also losing protein in the urine. So hypertension with proteinuria, that's what we will call as preeclampsia. Okay, and sometimes preeclampsia patient will also develop ankle swelling and some other complication. We will discuss that. Now, if a preeclamptic patient starts to have convulsion, that's what we will call as eclampsia. Okay, so these are the important terms that you guys need to remember first, because a lot of time people diagnose a patient who is 10 weeks and having hypertension, and it comes in the exam question that what is your diagnosis? And most of the candidates just think that it is a pregnancy associated hypertension or gestational hypertension, which is wrong. Okay. So if you go through here, this is called pregnancy-induced hypertension or gestational hypertension. So if systolic blood pressure more than 140 or diastolic more than 90, occurring first time after 20 weeks of pregnancy, that's pregnancy-induced hypertension. About the preeclampsia, there is mild and severe preeclampsia. According to JM, they say that up to 170 by 110, that's mild. But normally you can think about if it's up to 100 by 60, that's mild. If it is more than 160 by 100, okay, and that's severe preeclampsia. Severe preeclampsia patient sometimes can develop some of the complications. What are those complications? Patient can develop kidney impairment. They can have thrombocytopenia. They can have abnormal liver enzyme elevation. They can have headache, blurring of vision. They can have epigastric or right upper quadrant tenderness or pain. Now, preeclampsia patients sometimes can get complicated with a syndrome known as HELP syndrome. The HELP syndrome means H for hemolysis. So patient will have hemolysis. If patient develops hemolysis, they can develop anemia. They can also develop jaundice. EL for elevated liver enzyme. And LP, low platelet, so thrombocytopenia. If this is there, then we call it as a HELP syndrome, which is a very, very severe form of preeclampsia. Okay, and there is another term that we call impending eclampsia. If a preeclamptic patient develops headache, blurring of vision, epigastric or right upper quadrant tenderness, you should think it that it's most likely going to have an impending eclampsia. That means this patient is most likely going to have eclampsia in few days or weeks' time. Okay, so these are the important things that you need to remember. And then there is essential hypertension, which occurs before pregnancy or during first 20 weeks of pregnancy. If you want to confirm preeclampsia, what do you have to do? You need to confirm that if this patient is actually losing protein in the urine. So how you measure that? You can either do a 24-hour urinary protein level, or more easier is to do the urinary albumin creatinine ratio. Okay, so urinary albumin creatinine ratio, that's usually the best investigation to find out if this patient is actually having a proteinuria or not. All right. Yes, Dr. Madiha. So impending eclampsia means if a severe preeclampsia patient develops persistent headache, blurring of vision, right upper quadrant pain or tenderness, okay, those are the sign of impending eclampsia. And Dr. Fariha, if hypertension is diagnosed at 20 weeks, we will call it as gestational. Okay. So in here, this is from Lillian Jones, this page. So you can just give it a read. We already discussed about gestational hypertension. We are discussing about preeclampsia. If you look at here, this is more detailed. So patient will develop proteinuria more than 300 milligram in 24 hours. Renal insufficiency, so urea creatinine can get elevated. Liver disease, suggesting serum ALT, AST will be elevated, or epigastric or right upper quadrant pain or tenderness. Patient can have some neurological sign. So one is convulsion, severe headache, blurring of vision. And if you do check their upper limb, lower limb, you will find out this patient having hyperreflexia and ankle clonus positive. So hyperreflexia, ankle clonus, that is a very important sign for preeclampsia. Hematological disturbance, thrombocytopenia, hemolysis, these are very common, and sometimes fetal growth restriction. If a patient develops hypertension after 20th week of pregnancy, that means you're thinking about gestational hypertension, usually that hypertension will return to normal within 3 months after delivery. So it's not a permanent hypertension. Chronic hypertension, that means either it's essential or secondary hypertension. That means patient was hypertensive before getting pregnant, or patient developed hypertension in the first half of the pregnancy. Now, let's say a patient was previously diagnosed with hypertension, and then after 20 weeks, they are losing protein from the urine. What you will call it? You will call it as a preeclampsia superimposed on chronic hypertension. That means patient was already hypertensive, but on the top of that, they have developed preeclampsia. These are the risk factors of preeclampsia. Give it a read by yourself, not super important. The signs are very important, as we have been already discussing. What are the risks of preeclampsia? So mother can develop heart failure, kidney failure, coagulation failure, risk to the baby. You can give it a read. Management. Management is the most important part, which comes in exam. Now, the aim of the hypertension in pregnancy, that the blood pressure should be kept below 160 by 100. Okay, that's the aim, at least below this. So if a patient only develops gestational hypertension, you can start the patient with antihypertensive drug, but not all antihypertensive drugs you can give in a pregnant patient. So contraindicated drugs are ACE inhibitors or ARBs and diuretics. Commonly, what you can use, you can either use methyl dopa, that's for mild blood pressure raise. If it is a severe blood pressure or highly elevated blood pressure, then you can use oral or IV beta blocker. In case of a GP setting, we would use always a oral labetalol most of the time. Okay, so for pregnant patients, these are the two. Usually nifedipine also. So these are the three medication that is safe. So either methyl dopa, that's the first line. Then you have beta blocker or nifedipine. If a patient develops hypertensive crisis, okay, that means a severely elevated blood pressure, more than 200, in that case, we have to give them some IV antihypertensive, like either IV labetalol, hydralazine, or diazoxide. Okay. So that's your antihypertensive drugs that we can give for a patient with preeclampsia, not preeclampsia, like in case of gestational hypertension. Guys, can you just give me 2 minutes? Okay, just 2 minutes, I'm coming. Sorry. All right, sorry for the inconvenience. So we have been discussing about your antihypertensive drugs that we can use in preeclampsia, right? So these are the drugs. In case of preeclampsia or gestational hypertension, these are the medication that you can use, either beta blocker, methyl dopa, or nifedipine. Now, what are the guidelines that we need to urgently refer this patient? So if a patient developing severe preeclampsia, impending eclampsia, you can't control their blood pressure, or if you get HELP syndrome, obviously if a patient develops convulsion, if a patient develops neurological sign and symptom, those are the features that you need to send the patient immediately to the hospital. Now let's say how we treat a patient with preeclampsia. Now in case of mild preeclampsia, sometimes only thing that you need to do is to give them blood pressure lowering medication and control the blood pressure. But for severe preeclampsia, because this patient is a high risk to develop eclampsia later on, you have to send the patient to the hospital. And what what you can give for them, while you are waiting to send the patient to the hospital, you can actually start the patient with oral labetalol or nifedipine. But in the hospital, that patient will be needed IV form of antihypertensive, most likely IV hydralazine, IV labetalol, or diazoxide. Okay. Also, that patient will need magnesium sulfate. And this magnesium sulfate is mainly to prevent preeclampsia. So sometimes this dose comes in the exam. So the dose is 50% of 4 gram IV, followed by 1 gram per hour for a minimum of 24 hours. And magnesium sulfate is only given if the patient having a normal kidney function. Otherwise, patient can develop magnesium toxicity. If the patient, the gestational age is less than 34 weeks, then you will also need to give them a steroid injection, IM, to bring the fetal lung maturity. So this is actually the main treatment for preeclampsia: control blood pressure, prevent the convulsion, and if the patient is less than 34 weeks gestational age, then also give a steroid. The best treatment is termination of pregnancy with early delivery by cesarean section or vaginal delivery if there is favorable circumstance. Okay, so usually for severe preeclampsia, the best treatment is always a cesarean section, but if it is not very severe, then you can even try a trial of vaginal delivery if it is possible. If a patient develops convulsion, obviously you need to make sure their airway, breathing, circulation is normal. You have to give magnesium sulfate also for that patient. If magnesium sulfate cannot be given, then alternative is diazepam or clonazepam. And that's your HELP syndrome that we have discussed. Now in here, they have also written in a very good way that what will be the management of preeclampsia based on the severity. Okay, as you can see, for gestational hypertension, usually you will just monitor their blood pressure at home or maybe in the maternity unit. If it is very high, you can give them antihypertensive as well. For moderate preeclampsia, first of all, you have to monitor their blood pressure. You have to test their urine for protein, observation, bed rest. And also we have to admit the patient to the hospital, start the patient with either methyl dopa or labetalol or nifedipine. That means that patient will need antihypertensive. For severe preeclampsia, we will add magnesium sulfate with the blood pressure lowering agent. Most of the time, it has to be an IV form. So that's usually the management. We will go through the management a lot much deeper. So just hang on a second. Is there anything that can prevent preeclampsia? For women who is at high risk of preeclampsia, like who already have high blood pressure even before getting pregnant, type 1 diabetes, previous obstetric history shows patient had a preeclampsia before, those patients are high risk, so you can give prophylactic aspirin to them. You can also give calcium supplementation that can also reduce the risk of gestational hypertension. Okay, these are the two which is mainly proven effective. Now, based on the age of gestation, the treatment of preeclampsia will be a little different. So let's say a patient has developed preeclampsia before 32 weeks of pregnancy. Now, usually if a patient develops preeclampsia, that means it's not imminent eclamptic patient or eclamptic patient, just a mild to moderate preeclamptic patient. For this patient, our aim will be to prolong the pregnancy at least until 35 weeks of pregnancy. Because by the time it becomes 35, the lung becomes mature and the child usually will not have that much difficulty or complication after delivery. Okay. So that's what usually we would do. And Also, we will monitor the patient. We will do Doppler umbilical blood flow. We will do serial ultrasound, CTG. All of these things will be done regularly. Then if a patient develops preeclampsia between 32 and 35, it's the same thing. Normally, we would like to prolong it until 35 weeks of pregnancy. But if during that time, when you are actually monitoring the patient, if patient develops severe preeclampsia or imminent eclampsia, then you can't do anything. The choice would be either to go for induction of labor or cesarean section. Now, if it is after 35th week of pregnancy, you diagnose a patient with preeclampsia, then usually you can go for induction of labor or cesarean section, depending on the cervix condition and fetal condition. So after 35th week of pregnancy, you don't need to just prolong the pregnancy at all. Either you go for cesarean section or you go for induction of labor. It is important that women with a preeclampsia should not be allowed to exceed full term, because the risk of intrauterine death increases after term. So that's why if it's 35 or 36 week, you go for delivery either by induction of labor or by cesarean section. Now, if it is an eclamptic patient, obviously eclamptic patient is the highest risk of fetal complication. So if a patient develops eclampsia, you have to give them magnesium sulfate either by IV or intramuscular. IV is much preferred. There is loading dose and maintenance dose. We just discussed this. Please remember the dose of this one. Sometimes it comes in the exam. Now, because magnesium is excreted by the kidneys, you should not give it to someone who is having kidney failure. And because it can get toxic, that's why we need to monitor their tendon reflex, respiratory rate, and urine output when they are on magnesium sulfate. Now, if you find that patient developing respiratory arrest, like they stop breathing, they are having respiratory difficulty, stop the magnesium sulfate, start the patient with calcium gluconate, because that is the antidote for magnesium toxicity. Then there is respiratory depression. If patient develops respiratory depression, again, stop the magnesium sulfate, start the patient with calcium gluconate. If there is absent patellar reflex, but respiration is normal, stop the magnesium sulfate until the reflex return. But if the respiration is depressed, then treat just like this one. So if the patellar reflex is absent, then usually we should just stop the magnesium sulfate until the reflex are normal. If there is poor urinary output, like urine output less than 100 ml in 4 hours, in that case, reduce the rate of IV infusion and monitor the fluid balance. Okay, so that's how we manage this patient. And these are the dose. So loading dose is 4 gram IV over 5 to 15 minutes, and maintenance is 1 gram per hour for 24 hours. Now, any patient who develops convulsion or eclampsia, once you stabilize the patient, you should go for termination of pregnancy, no matter what is the age of pregnancy. So that's all about your preeclampsia. Okay. Any question with preeclampsia, eclampsia? It's a very important topic. That's why I discussed it in a very detailed way. Next is anemia in pregnancy. We call, like, if a patient develops hemoglobin level less than 110, that means this patient is having anemia during pregnancy. And obviously, it's very common to develop iron deficiency during pregnancy. And that is the most common cause of anemia during pregnancy as well. What else it can be? It can be megaloblastic anemia due to B12 or folic acid deficiency, or sometimes even it can be thalassemia. Now, management is dependent on the cause. So if you get anemia, like hemoglobin is low in pregnancy, what is the next test that you're going to do, guys? So the full blood count actually gave you the hemoglobin low, right? So yes, iron studies. So we'll do the iron studies, and that will rule out possibility of iron deficiency anemia. If iron comes normal, then you will check for thalassemia by doing a hemoglobin electrophoresis, and also you will check the B12 and folic acid level. And treatment will be according to the cause. Diabetes during pregnancy. Diabetes during pregnancy it's a very important complications, because sometimes type 1 diabetes especially can cause a lot of complication for the baby as well as in the mother. So especially diabetic child can become macrosomic, that means they can be very large for death. Fetal abnormalities, a lot of abnormalities can happen. And also sometimes growth restriction, preterm delivery, miscarriages can also happen. And mother can develop preeclampsia, polyhydramnios, a lot of complication. This is not important for you. If you get a patient who is diabetic during pregnancy, you should refer the patient to a diabetic specialist and an obstetrician. Make sure you check their basic diabetes control test like blood sugar, HbA1c, their kidney function, everything. In this patient, normally we assess them for fetal morphology. We do ultrasound at 18 weeks, then 4 weekly. Okay. Now, for a patient who is diabetic during pregnancy, what will be the management? Now, if it's a type 1 diabetes, it's a little different from gestational diabetes. For a type 1 diabetes, obviously, we need to make sure that they might be already on insulin if it's a type 1 diabetic. So they must be in a good control of diabetes during the pregnancy. But the delivery, if patient having optimal control of diabetes, then vaginal delivery can be done. But if the baby is very large, like more than 90th percentile of weight or more than 4 kilo, then usually we go for cesarean section. Now, a very important topic is gestational diabetes. Gestational diabetes means when you first time diagnose or get a high blood sugar or abnormal glucose tolerance during pregnancy. If you get a high blood sugar level during pregnancy, the next test that you need to do to confirm the diabetes is oral glucose tolerance test, OGTT. There was a test called GCT, glucose challenge test. We no longer do that. We only do OGTT. So forget about it. In RACGP guideline, still somewhere you will find this out, but no one doing this GCT anymore in here. So that should be always OGTT. Now, it should be performed in the first trimester if a patient having a strong family history or previous gestational diabetes history. So patient, like a pregnant patient, will have some screening test according to their age of pregnancy. Normally, if a patient is not having any high risk of diabetes, we will check for diabetes at 26 to 28 weeks of their pregnancy. That's for everyone. But if the high risk patient should have their diabetes assessment in the first trimester. Okay, so whenever you are doing the first antenatal blood test, you have to also do their blood sugar level. Diagnosis: if fasting blood sugar more than 5.5 or 2 hour more than 8.5. Management: usually the management will be first lifestyle modification. If lifestyle modification is not helping, then we go for insulin. So that's most of the time we go for it. We don't follow the same principle like a normal diabetic patient. So normal diabetic patient, type 2 diabetic patient, we would first start with lifestyle modification. Then we will go for oral anti-hypoglycemic agent like metformin, sulfonylureas. If that does not help, then insulin. But for gestational diabetes, after lifestyle modification, next choice of action will be insulin. The follow-up of gestational diabetes comes in exam and is very important because if a patient develops gestational diabetes, there is a 30% risk of developing diabetes later on in their life. So just to avoid that, you need to follow up the patient for at least every 5 yearly. So follow up with OGTT at 6 weeks and then every 5 yearly. So that is the follow-up for gestational diabetes. It comes in exam many times, a very important one. Thyroid disorders. Thyroid disorder, it is like if hypothyroidism is not very common, but hyperthyroidism can develop. So any patient who is having hypothyroidism or features of thyroid problem, thyroid function test should be checked at first presentation and at 36 weeks. And if the patient is having hypothyroidism, you have to give them thyroxine replacement therapy. And normally we use a increased dose of thyroxine during pregnancy because during pregnancy, the patient usually need more thyroxine than usual. And hyperthyroidism usually developed by Graves' disease. And this patient also needed to be treated because if you don't treat hyperthyroidism in pregnancy, there is a risk of complication. What is the preferred treatment? In the first trimester of pregnancy, that means first 3 months of pregnancy, we go for propylthiouracil. And after 3 months of pregnancy, carbamazepine will be your preferred treatment. Carbamazepine is usually the first line for anyone. But during first trimester, we will not give carbamazepine. Okay, because it can cause some fetal complications and also some abnormal defect. Cardiac disorders, not very important, give it a read. Kidney disease, also give it a read. SLE, systemic lupus erythematosus. If a patient with SLE become pregnant, they have an increased risk of complications like preeclampsia, prematurity, those things. They have also increased risk of spontaneous miscarriage. Now, if a patient with SLE develops or have a history of recurrent miscarriage and also having a history of deep vein thrombosis, you should always rule out antiphospholipid antibody syndrome. And how we check it? You have to do some autoantibody test, which is your anti-cardiolipin antibodies and lupus anticoagulant as well. And if a patient having antiphospholipid antibody syndrome, then that patient should be on either aspirin or low molecular weight heparin from 14 weeks of pregnancy to the rest of the pregnancy. Okay. Sometimes a patient with lupus, the children or neonate can develop a condition called neonatal lupus syndrome. And also they can develop fetal bradycardia after birth. And that is also very common in lupus, like children who gets born in a SLE patient. All right. Any questions so far, guys? Then there is thrombocytopenia. The two most common cause of thrombocytopenia in a pregnancy is either it's a gestational thrombocytopenia or immune thrombocytopenia. And there are also some other causes which can cause low platelet in pregnancy, like SLE, antiphospholipid antibody syndrome, drug-induced, or HIV. Now, gestational thrombocytopenia is common, and it mainly happens in third trimester. Okay, but why it is important that because of increasing hazard of epidural anesthesia, when platelet count goes down less than 75, a 2-week course of prednisolone is prescribed at 37 to 38 weeks of gestation. So normally at the end of the pregnancy, like third trimester, you want to keep the platelet count more than 100. Okay, so just at that time, 37, 38 weeks of gestation, we will give a course of prednisolone. Then there is jaundice related to pregnancy. A lot of causes are there which can lead to jaundice during pregnancy. One of the common is viral hepatitis. Sometimes eclampsia, preeclampsia can cause it. And then there is two specific conditions just for pregnancy. One is cholestatic jaundice of pregnancy and acute fatty liver of pregnancy. Acute fatty liver of pregnancy is very rare, but it is very serious condition. Why the cholestasis of pregnancy happens? Because of estrogen sensitivity. The symptoms are very mild, usually low-grade jaundice and pruritus during the latter half of the pregnancy. So normally we need to monitor the fetus, and usually we go for delivery before 30 weeks of gestation. Okay, before 38 weeks of gestation. We perform the liver function test and consider giving a vitamin K supplement. And most of the time, these cholestasis get better after delivery. No, and also we say that if a patient develops cholestasis during pregnancy, we should not offer them oral contraceptive, because oral contraceptive can increase the risk of cholestasis again. So that's why it is contraindicated. Fatty liver of pregnancy, not very important. Epilepsy in pregnancy. That's very important topic. Epilepsy in pregnancy. Now, this is one of the conditions which can get worse during pregnancy. That means pregnancy itself can increase the number of seizures. So that's why making sure patient is very well controlled, it is very important for this patient. It is important to take folic acid, and it's a high dose folic acid. So normally every pregnant patient should take folic acid 0.5 milligram 1 month before pregnancy and 3 months after pregnancy. But for few patients, like patient who is taking anti-epileptic drug, they should be on a high dose folic acid to prevent any neural tube defect. And that is a 5 milligram folic acid that we give to them. Now, all anti-epileptic drugs are potentially teratogenic, and it becomes very confusing that which drug we can use and which we can't. So phenytoin, no longer phenytoin is the first line anti-epileptic, so we don't need to worry about it, but it can cause cleft lip, cleft palate, congenital heart disease. Sodium valproate can cause neural tube defect. And that's why sodium valproate, usually we would avoid giving it during pregnancy because that can cause neural tube defect. And almost all antiepileptic drugs are excreted in breast milk also. Now, a couple of questions will come from epileptic management. Like, let's say a patient is on sodium valproate, and now patient coming to you for a pre-pregnancy counseling, that what they will do because they want to get pregnant. So what you will do? First of all, you need to find out how well controlled is their epilepsy. If epilepsy is well controlled for the last 2 years on this medication, that means patient is safe for pregnancy and they can go for pregnancy. And what you can do over the time, you can reduce the dose of sodium valproate and change it to another medication which is more safe, like carbamazepine, lamotrigine, those you can use. But if a patient becomes pregnant while she was taking valproate, and now, like let's say a 10 weeks pregnant coming to you for the first antenatal visit, and she was taking sodium valproate until this time. Now, at that time, you don't need to stop the valproate because one thing is that you might risk the patient to develop seizure if you stop it, or you can, even if you change it to safer one, patient seizure may not be well controlled with that. So if a patient become pregnant while they are on sodium valproate, we will not bother with changing the medication because that's too risky. We will talk about the risk of it and we will gradually follow up the patient. That's all that we can do. Okay, is this understandable? The questions come from here in a lot of ways. If you don't understand this basic, you will feel very confused. But if a patient needs to be on anti-epileptic and they want to breastfeed, then sodium valproate will be the best choice. So breastfeeding women, valproate, but pregnant time, you cannot give them valproate. If you can, you should change it to either carbamazepine or something more safer like lamotrigine. Okay. Same for phenytoin, yes. And antiphospholipid syndrome it's usually a patient with SLE who develops recurrent miscarriages and deep vein thrombosis. That's antiphospholipid syndrome. Usually we do the cardiolipin antibodies or anti-cardiolipin antibodies for diagnosis of this. All good so far? Any question? So that's pretty much everything that you should know about the high-risk pregnancy. Now we will move into the complicated pregnancy, which is your antepartum hemorrhage. Okay, what I would like to do, because this is a whole new topic, let's take a 10-minute break now, and then we will start with this topic. Because until now, it was very boring, as I understand. But antepartum hemorrhage, PPH, those will be more interesting. So we'll start with that after the break. Okay? So 10-minute break for now, and then we will start with the postpartum hemorrhage and antepartum hemorrhage. All right, guys, let's start with antepartum hemorrhage. Okay, so what is antepartum hemorrhage? Same like preeclampsia, if bleeding happens after 20th week of gestation and before onset of labor, that is what we call as antepartum hemorrhage. So bleeding from parvaginal area after 20th week of gestation and before labor. Okay. If hemorrhage occurs less than 24 weeks, then we treat it as a threatened miscarriage. If it occurs after 26 weeks, then we admit the patient for management. Remember to give NTD if the mother is Rh negative. Okay. Do not perform a vaginal examination if a patient having bleeding from their parvaginal area. So what are the major cause of antepartum hemorrhage? Placental previa and then placental abruption. Which one is more risky for fetal death? Placental abruption. Okay. Now, let's discuss placenta previa. Normally, placenta should be on the upper part of the fundus of the uterus. So if this is the uterus, placenta should be in the top part or at the fundus of the uterus. But when placenta goes down on the lower part of the uterus and sometimes even cover the internal os or opening of the cervix, that is what we call as placenta previa. And it has few grade also. So grade 1 to grade 4. Grade 1 and 2 is called minor placenta previa, and grade 3 and 4 called major grade of placenta previa. Now, usually if a patient after 20th week of pregnancy comes to you with a painless vaginal bleeding, usually we would think about placenta previa as our first diagnosis. If it is a painful PV bleeding, then it's either placental abruption or preterm labor. Okay. So these are the 4 types of placenta previa. As you understand that, see that placenta is now low lying, and this is the internal os. Now, if it's not touching the internal os, that's grade 1. If it is just touching the internal os, like it should be like up to here, so just touching, that's marginal placenta, that's grade 2. So this 2 is the minor. Now, if it comes across the internal os but does not completely occlude it, that's partial previa or grade 3. And when it totally obstructs the internal os, that's complete previa. Obviously, if placenta is lying over here, there is no way baby can descend down into the pelvis for delivery. So for this patient, 3 and 4, you have only choice of doing cesarean section. But sometimes in grade 1, sometimes we can give it a try of vaginal delivery. But most of the time, placenta previa will need cesarean section. So what is the management of placenta previa? The management, first of all, because patient is bleeding, you need to resuscitate the mother. So insert IV line, take the blood for grouping cross-matching, start the patient with IV fluid, and then if it's still patient bleeding and blood, when the blood comes, then you can also give the blood transfusion. And once you stabilize, you have to also confirm the grading of placenta previa by doing an ultrasound. So confirm your diagnosis by ultrasound. Our main aim will be to prolong the pregnancy at least up to term if we can. But in case of major grade of placenta previa, we have to admit the patient to the hospital for watchful expectancy or observation. Okay. We have to give NTD if patient is Rh negative. Now, there is a lot of investigation and lot of management is there, but you don't need to do that. You don't need to remember it. Remember one thing, if it's a major grade of placenta previa and more than 34 weeks of gestational age, that patient will be admitted throughout like the rest of the pregnancy, patient will be in the hospital. If patient is not bleeding anymore, then you can just try to prolong the pregnancy until term. But if patient starts bleeding or bleeding continues that you can't stop it, then you have to arrange urgent termination by cesarean section. And cesarean section should be always done for the major grade of placenta previa. Vaginal delivery should not be attempted. Elective cesarean section is usually performed at 37 weeks gestation. If you see that patient is not bleeding anymore, or very minimal spotting is there, no fetal distress, no maternal distress, then you will just continue the pregnancy until 37 weeks, and then you go for elective cesarean section. Okay. If it is a minor grade of placenta previa, then even it's more than 34 weeks of pregnancy, usually patient will be admitted, but then just watchful expectancy, and you can try for a vaginal delivery if it's a grade 1, but most of the time elective cesarean section will be the choice. So it depends on the bleeding. If patient's bleeding is stopped, then you can just try to prolong the pregnancy up to 37 weeks. But if bleeding is not stopping, patient or mother or the baby is getting distress, then you don't have any choice but to go for CS. Next is abruptio placenta. Abruptio placenta means that normally what will happen that when your baby will be delivered first and then the placenta will come out. That's the rule, right? But if placenta get detached from the uterine wall before the delivery, that's what we call as abruptio placenta or placental abruption. Now, because it's getting detached from the uterine wall, the uterine blood vessels will start bleeding here. Sometimes bleeding can come out and you can have a PV bleeding with abdominal pain. Sometimes bleeding can be concealed. That means it will start collecting inside the uterus. Patient will have severe pain but no bleeding. So when bleeding comes out of the vagina, that's revealed variety of placental abruption. And when it does not come out and patients getting severe abdominal pain and their symphysiofundal height gets higher than the gestational age, those are the time you're thinking about concealed variety of placental abruption. So the patient presents with mid-abdominal pain, bleeding PV, tense and tender uterus, sometimes even larger for date, and sometimes if it's severe bleeding, patient will go into shock. There is a lot of etiology or cause of abruptio placenta, but multiparity, cigarette smoking, cocaine abuse, polyhydramnios, that can be more common. Sometimes even after a motor vehicle accident, patient can develop abruptio placenta. That's why any patient having an accident or trauma to the abdomen during pregnancy should be tested or observed for abruptio placenta. Management. Because patient is bleeding, you need to make sure you resuscitate the patient, just like always. After the resuscitation, you will do some of the blood tests. You will also do an ultrasound and CTG to confirm that it's not a placenta previa, and CTG to assess if there is any fetal distress. If the gestational age is less than 34 weeks, we will also give a course of a steroid. The aim will be for vaginal delivery in here. Now, it depends on the baby as well. If the bleeding is stopped and patient not having too much abdominal pain, fetal distress is not there, mother is stable, then you don't need to go for urgent delivery. You can wait and watch and go for induction of labor during term. But if the patient is bleeding heavily, that the baby is in distress or mother is getting hypovolemic shock, that time you have to go for urgent cesarean section. So cesarean section is recommended when the baby's life is immediately threatened. But most of the time, if patients bleed heavily, then the baby will be dead. So that is what we call as intrauterine fetal death, IUFD. If fetal death happen, then usually you should not go for cesarean section. You wait for normal vaginal delivery. Okay, so most of the time you will just wait for the delivery to happen, and sometimes even you can just do a induction of labor by amniotomy. Okay, so if baby is dead, then usually you don't need to go for CS. You go for first go for rupturing the membrane, which is your artificial rupture of membrane or amniotomy, and followed by vaginal delivery. Okay, so these are the management that you need to remember. So give it a read of the management from here as well. So that's the revealed variety that you can see, and that's the concealed variety. Which one would be more painful, concealed or revealed? Concealed, because blood is collecting inside. Which one you will get symphysis of fundal height more than gestational age? Concealed, right? Because the blood is collecting, so uterus will be larger. So this is the difference between placenta previa and abruptio placenta. Give it a read. We already discussed everything in here. Then there is a condition called vasa previa. It is also a cause of antepartum hemorrhage, but it occurs due to rupture of fetal blood vessel. So sometimes during artificial rupture of membrane, if somehow you injure the fetal blood vessel, that can cause this vasa previa. Okay, so what will happen? The patient will start bleeding suddenly when you started to do the rupture of membrane. And that's the diagnosis. And if you do a CTG at that time, you will see that baby is getting distress. And in that case, again, emergency cesarean section should be done. So that's all about your antepartum hemorrhage. Next, primary and secondary postpartum hemorrhage. So primary postpartum hemorrhage is a loss of more than 500 ml of blood within 24 hours of delivery. So postpartum hemorrhage means if bleeding happens after delivery. If bleeding happens within 24 hours of delivery, that is primary PPH, and between 24 hours to 6 weeks of pregnancy, if bleeding happens, that's secondary PPH. The most common cause of primary PPH is uterine atony, in which uterus becomes very lax. Okay, so normally after delivery, uterus starts to get contracted and hard, and that's how it stops bleeding. But in uterine atony, uterus becomes lax and very soft and relaxed. So that's why for uterine atony, the management is to go for fundal massage. So you just massage the uterus, and it can sometimes start the contraction. Apart from uterine atony, we have retained product of placenta, genital tract laceration like episiotomy, cervical tear, perineal tear, ruptured uterus or inverted uterus, or coagulopathies. So these are the main causes of primary PPH. Again, management is important. So when a patient having bleeding, we always resuscitate the patient. That's the first thing that we do. For a patient who is having primary PPH and the uterus is lax, once you have resuscitated the patient, like at least inserted an IV line, start the fluid, send the blood for cross-matching, start rubbing the fundus. That's the most important thing that you need to do. So rubbing up the uterus fundus, you can also give them oxytocin or argometrin, which will also increase the contraction of the uterus. Okay, and what else we will do? So if you look at here that first of all, IV access, sending the blood. If patient is having low oxygen, then give oxygen. Then we will also start the patient with IV oxytocin. And if even after that patient is bleeding, then we go for argometrin. Okay, and sometimes even after that patient bleeding, you can give misoprostol per rectum. And if there is a retained placenta that you get, then you have to go for controlled cord traction to deliver the placenta. If controlled cord traction fails, then manual removal of placenta. If patient continues heavy bleeding, then next option is bimanual compression or balloon tamponade. Okay, and sometimes even more complicated operation will be needed. In between that, if patient is having a full bladder, you should also catheterize the patient. If placenta is delivered, you should also inspect the placenta to find out that if it is complete or some part is still there. You should also do an speculum examination of the genital tract to rule out any genital tract laceration. Okay. So if atonic uterus is not controlled by oxytocin, next you will go for argometrin. If argometrin does not help, then sometimes intramyometrial prostaglandin can be injected. And then last options are balloon tamponade, uterine artery ligation, internal iliac artery ligation, or even hysterectomy. Now you don't need to memorize this stuff because it does not come in the exam. The initial part is important, that IV fluid, then oxytocin, making sure you also go for fundal massage. Okay, so that's the important part. So if you look at here, this is the stage. So if you get a patient with postpartum hemorrhage, you are checking the placenta to determine if it is complete, massage the uterus, set up an infusion of Hartmann solution, and start the patient with oxytocin and argometrin. The oxytocin in here is known as syntocinon, so same stuff. Now, if bleeding continues in spite of firm uterine contraction induced by the oxytocin, then you should inspect the genital tract for laceration. So the main thing is fundal massage, syntocinon, argometrin. Bleeding persists, bimanual compression of the uterus. Still bleeding there, then intrauterine balloon catheter for balloon tamponade. And then there is some other operative treatment out there which is not needed for you. Okay, so until that, if you can remember, that should be enough. Any question with the primary PPH? Next is secondary postpartum hemorrhage. The most common is poor epithelialization of the placental site. That means the placenta obviously has been removed, and then the site where placenta was attached to the uterine wall, if that site is poorly epithelialized or not well healed, that's the most common cause. Then it could be retained product of placenta, or sometimes even infection in the uterine wall like endometritis. So to rule out any possibility of placental fragment is still inside, you have to do an ultrasound. In those cases, you can get that uterus is still bulky, sometimes even tender, and cervix open. The initial treatment is to give syntocinon or argometrin, and if there is a possibility of infection, then give antibiotic. If you get product of placenta is still there, then you have to go for suction curettes or just dilation and curettes. So that's from your GEM. So if patient starts bleeding from 24-hour up to 6 weeks postpartum, that is secondary PPH, the causes are written product, infection, laceration, or coagulation. We have to do investigation to find out there is nothing inside. IV oxytocin, argometrin if the patient is bleeding. You can try pararectal misoprostol as well. If the ultrasound shows patient having any product of placenta inside, then you have to go for gentle blunt curettage under general anesthesia. Okay. If patient having features of infection, especially if a patient having bleeding, patient having fever and foul smelly vaginal discharge, and uterus is bulky, very tender, that time you think about a condition called endometritis, not endometriosis, different. Okay, so endometritis means infection of the endometrium. That's the outer wall of your uterus. So if endometrium gets infected, the patient will have those features. You have to start the patient with antibiotic. So antibiotics are amoxiclav, metronidazole, and gentamicin. So that's your antibiotic you have to start. This antibiotic name comes in exam, so remember it. So that's mostly about secondary PPH. Any question with the postpartum hemorrhage, guys? Next, blood group isoimmunization or RH isoimmunization. Now, RH isoimmunization, it's a long topic to discuss, but for your exam, you just need to remember. So what happens in here is that if a RH negative woman, the partner is RH positive, and the baby becomes RH positive also. So what happens that this is the first pregnancy that I am talking about. In the first pregnancy or first baby, because these counteract each other, during delivery, if there is any mixture of fetal and maternal blood, so what will happen that maternal antibody, or you can say that this, if the RH positive blood goes into mother's blood will develop an antibody against this RH positive blood. Now, the first baby will not have any problem because he is already delivered, right? But the second baby, if the second baby is also RH positive, and mother is now having in her blood the antibody against this blood. So what will happen? Even during pregnancy time, if there is a little bit of fetal-maternal blood transfusion, then this antibody from the mother's blood can start destroying the fetal blood. And that causes the hemolysis of the fetal blood. Okay? The child can develop hydrops fetalis, even if this can cause fetal death as well. So that's what is RH isoimmunization. Now, how we can prevent that? If we give an anti-D antibodies during the first delivery, then the mother will not form that antibody. And then the second time, it will be safer. So that's why any Rh negative women usually will have NTD injection after delivery within 72 hours. Not only just that, every Rh negative women should be screened for NTD antibodies in their blood. First time when they present at you at 28 weeks and at 34 to 36 weeks. Okay, if mother blood already having NTD antibodies, then you don't need to give NTD to them. But if the mother body does not have any antibodies, then yes, we go for NTD injection during this time. So at 28 weeks, you will give an NTD. At 34 weeks, you will give an NTD antibody. And after delivery, again, you will give an NTD antibodies. Okay, so that's how we manage these patients. Any question, anything that you want to know? The whole thing, Dr. Aisha? Okay, the last part, that's good. So in this case, the last part, if we want to say that normally every woman should be screened for Rh, like every Rh negative mother should be screened for NTD antibodies at presentation. That means whenever they first time come to you, then at 28 weeks, and then at 34 to 36 weeks. Now, during their presentation, especially at 28 weeks and 34 weeks, if the patient's blood does not have any NTD antibodies, then yes, we will give them NTD antibodies to protect them from this Rh immunization. Okay, during one dose at 28 weeks, another at 34 to 36 weeks, and another after delivery. And it's not only just during this time, there are some of the other time where we have to give NTD to the Rh negative mother who does not have any NTD antibodies in their blood. So if a patient have spontaneous miscarriages at any time of pregnancy, you have to give NTD to them. Now, after threatened miscarriages, we don't give NTD in Australia, so forget about it. After delivery, yes. After termination of pregnancy or ectopic pregnancy, following any sensitizing event like amniocentesis, then CVS, okay, then antepartum hemorrhage, external cephalic version, any abdominal trauma, any of these events, there is a risk that there will be a fetal-maternal transfusion. So you have to give them NTD even after this. And prophylactically, we give at 28 and 34 weeks in an apparent normal pregnancy. So these are the time when we go for NTD injection to the mother. And CVS is your chorionic villus sampling. That's a test that we do for Down syndrome. Yes, even in first pregnancy, we have to give NTD to them. Now, sometimes there is a test called Cloher test. This Cloher test is done on maternal blood after a sensitizing event to find out how much fetal-maternal transfusion has been happened and how much dose of NTD immunoglobulin this patient will need. Okay. So that's all about Rh-IC immunization. You don't need to go further than that. Next is preterm labor and premature rupture of membrane. So what is preterm labor? Preterm labor means, like, obviously In Australia, we call term means 37 to 42 weeks. If a patient starts to have labor pain before 37 completed week, that is what we call as preterm labor. So after 20 weeks and before 37 week, if labor starts, that's in preterm labor. There is a lot of causes of preterm labor. Give it a read. So patient will come to you with pain in the abdomen, which comes and goes. That means that whenever the contraction happens, then the pain comes. And it will come as a regular contractions. Now, if a patient develops preterm labor, sometimes what you can do, obviously preterm labor patient, if it's say in the rural setting, you can't keep the patient in the rural setting, you have to send the patient to a tertiary hospital. Now, before sending the patient to a tertiary hospital, a couple of things that can be done is, one, you can give them tocolytic agent to prevent or to prolong the pregnancy a little bit, because tocolytics are supposed to inhibit the uterine contraction. So first dose of tocolytic agent you can give while you are transferring the patient to the tertiary hospital. If the patient is less than 34 weeks, then yes, you have to go for steroid injection also to bring the lung maturity of the baby. This is the two things that you need to give to them. In the obstetric unit or tertiary hospital, they will be checked by obstetrician. If they're not having full labor or active labor, then the obstetrician can consider using tocolytic agent. Usually the tocolytics that we use, the preferred is nifedipine, then atosiban, salbutamol, even magnesium sulfate. So those are the tocolytics that can be used. All right. Sometimes when you do the vaginal examination, especially the speculum exam, you can also do a test by taking a vaginal swab called fibronectin test. So fibronectin test, if it's positive, it suggests patient is going to have delivery in 1 week time. And it can also say that this patient is having a preterm labor. Okay, if it's negative, then you can be assured that most likely labor is not going to happen in the next 1 week time. And preterm labor, this is actually the management, but if labor starts and the labor progresses to the active labor, then there is nothing you can do. We just need to go for the delivery. Premature rupture of membrane. Now, normally what happens that first labor pain starts, then there will be rupture of membrane. Now, if it happens opposite, like first rupture of membrane happens, then labor pain starts, that's what we call as premature rupture of membrane. Now, if premature rupture of membrane happens before 37 weeks, that is what we call as preterm premature rupture of membrane. Okay. Now, premature rupture of membrane, it means that most likely the patient is going to have a labor as well in few days' time. So 50% of premature rupture of membrane progress to labor within 24 hours and 80% within 7 days. Smoking is a risk factor of it. Always remember, never ever do a vaginal examination in a patient who is having suspected PROM, because you can induce infection in the placenta also. And that is what we are worried about, chorioamnionitis. So if that happens, then maternal fever, tachycardia, high WBC count will be there. And that's the time we have to go for urgent delivery. So what we normally do in this patient is that first you perform a routine examination, then you do the vaginal speculum exam. So you don't insert your finger, which is your bimanual exam in here, but you can do a speculum examination. In a speculum examination, if you see that there is pooling of liquor in the posterior fornix, that's most likely amniotic fluid. You can take that fluid and do a test called nitrogen test. And nitrogen test can confirm that it is amniotic fluid or not. And also we will take a vaginal and cervical swab for culture. Once you have taken the swab, then you start the antibiotic erythromycin. And you perform there, and then you do the blood test regularly every 2 to 3 days to find out if the patient developing any sign of infection. If there is no sign of infection, the swab result come back negative, then you can stop the antibiotic. You will also continue the ultrasound CTG every second day. If any time patient develops features of infection or blood test suggests features of infection or CTG gets abnormal, you go for urgent delivery, usually induction of labor. Now, if there is no infection, then again, you will go for elective induction of labor by 36 weeks. You will not prolong it up to 37. Okay, so by the time it's 36 weeks, even if there is no infection, no labor is started, you have to induce the labor. And same like preterm labor, premature rupture of membrane, if you are in a rural hospital, you have to send the patient to the tertiary hospital. Okay. Then prolonged pregnancy. So if pregnancy lasts more than 42 weeks, that's what we call as prolonged pregnancy or post-dated pregnancy. So normal delivery should be between 37 and 42 weeks. At 41 week, check CTG and amniotic fluid index. You can still allow the patient to proceed for normal delivery if CTG and amniotic fluid index is normal. But by the time it's 42 weeks, if still no labor, then you induce the labor. Induction you can do by prostaglandin vaginal gel or vaginal misoprostol followed by artificial rupture of membrane. Okay. So that's your post-dated pregnancy or prolonged pregnancy. Then there are some of the conditions in which you will get fundal height greater than the gestational age. Like let's say a patient gestational age is 30 weeks and the fundal height is 34 centimeter. Normally, if it's a 30 weeks pregnant patient, the fundal height should be 30 plus minus 2. That's normal. But when it becomes more than 2, it's not normal. So this is what we call as fundal height greater than gestational age. So there are some causes of it. One is polyhydramnios, so excessive fluid around the placenta or around the baby. If it is a twin pregnancy or multiple pregnancy, if the baby is macrosomic, like a diabetic baby, fibroid, or if it's a wrong date. So first thing that you rule out is wrong date. If it's not a wrong date, then you try to rule out all other causes. If you suspect it's most likely a polyhydramnios, you have to do an ultrasound to confirm it. Then sometimes fundal height can be less than the gestational age, and most common cause is oligohydramnios, in which the liquor or the amniotic fluid amount reduces even less than 500 ml. Or sometimes if it is an intrauterine growth restriction, wrong date, small baby, that can also cause it. Investigation should start with ultrasound, kidney function test, lupus antibodies, and regular CTG. You can give it a read of IUGR, not very important. One thing that you need to remember about intrauterine growth restriction, that if the birth weight is less than 10th percentile, that is what we call as IUGR. And a small baby can have a lot of complications. So if you get a fundal height less than the gestational age, that is one of the time you will consider that is the baby growing well. So then you try to rule out IUGR. Patient with IUGR will also have oligohydramnios and reduced fetal movement. The management involves first do an ultrasound and refer to a specialist. Other investigation that can be done is umbilical blood flow and CTG. Okay, then there is meconium stained liquor. Meconium stained liquor means most of the time, if it is a post-dated baby or post-term pregnancy, sometimes the amniotic fluid can be meconium stained. And meconium staining is a sign of fetal distress. But if it's only meconium alone, don't think that patient is in distress. Usually you have to do the full Apgar score to find out if the baby having any asphyxia or hypoxia. But yes, meconium stained liquor is a sign of fetal distress. So you have to rule that out. If you get a meconium stained liquor, you should also rule out cord prolapse if you can. So assess the fetal condition by CTG, perform pelvic examination, rule out cord prolapse. If everything is fine, allow labor to proceed for a vaginal delivery. But if you get abnormality in the CTG, then you have to take the fetal scalp blood, check for pH and lactate level. If lactate is high or pH is low, showing acidosis, then you have to go for cesarean section. And always during, if meconium stained liquor is there, we always keep a pediatrician beside us because most of the time the baby can have asphyxia or patient can develop meconium aspiration during delivery. Okay. You guys are understanding. I understand that this is a lot to take and a lot of things coming to your head at the same time. You guys are understanding? Good. Now, some other condition like malpresentation. The common malpresentation are breech presentation and transverse lie. So normally what happens, so baby should be in the head down position in the pelvis, right? So forget my drawing. Now, if it is a head down position, that is actually the normal presentation, or you can say that is a cephalic presentation. Okay. But sometimes it can be totally opposite, like baby's head goes up and bottom comes in the pelvis. That is what we call as breech presentation. When baby is lying along the axis of the maternal uterus, like if this is the uterus and baby is lying along the axis, or you can say parallel to the maternal uterus, not parallel, perpendicular, you can say, that is what you call as longitudinal lie. Now, sometimes what can happen, if this is the uterus, baby can lie sideways. If sideways like this, that is what we call as transverse lie. If baby's lie is oblique like this, that is oblique lie. Okay, so these are the common malpresentation that we are looking for. And usually for this malpresentation, the best practice is to go for cesarean section. That's the mode of delivery. So general rule for breech presentation is to delivery by cesarean section. In some patient, you can try vaginal delivery, okay, especially if you see that patient is going for a spontaneous labor, having a normal sized baby and normal pelvic dimension. Normally what we do in a breech presentation, there is a thing that we can do called external cephalic version. So until 36 weeks, we will not do anything because sometimes breech can become cephalic because baby is rotating around the uterus. So by the time it becomes 36 weeks, you again assess the baby for the presentation. If still it's breech presentation at 36 weeks, then you can go for cephalic version. So what you do, you externally try to bring the baby into the cephalic presentation. Okay. Now, the optimum time to do it is in between 36 to 38 weeks. The best is 37. Now, sometimes it might not be successful, so you have to warn the patient. And sometimes even patient can require emergency cesarean section during external cephalic version. So always when we do the ECV, the obstetrician usually will keep all the measures of cesarean section beside her because sometimes emergency CS might be needed. Before you go for external cephalic version, we will do an ultrasound to check the status of the baby, including its size. If the baby is not very large, like not more than 4 kilo, if the baby's head is not hyperextended, then you can proceed for external cephalic version. If it is unsuccessful, then you go for elective cesarean section at 38 to 39 weeks. Okay. Now, these are the types of breech. You don't need to remember it. Just remember what is breech. That should be fine. For transverse lie, again, you have to perform an ultrasound. If you can try the external cephalic version at 36 or 7 weeks. If it is not successful, then you go for cesarean section by 37 or 38 weeks. Only once. We usually do only once ECV is all that we can do, not multiple times. Then there is cord prolapse. Now, if you find out, like during your examination of the pelvis or vaginal examination, if you see that the cord is coming out of the vagina or maybe out of the cervix, that is what we call as cord prolapse or cord presentation. So when you diagnose it, feel the cord. If the cord is still pulsating, then push the presenting part away from the cord. Like let's say if this is the head and this is the cord coming out, so head can compress the cord, and if cord is compressed, then baby will not get blood supply. So what you do with your hand, you can push the presenting part away and also try to push the cord as far as possible and keep your hand at that place by continuous digital pressure. And you organize urgent cesarean section while maintaining the position of the hand. That means someone else will do the cesarean section, your hand will be there. If women is fully dilated, like in the second stage of labor, and cervix is favorable, then you can try vaginal delivery with forceps or vacuum. Okay, so that's how you manage it. So initial step will be to push the presenting part away with your hand if the cord is pulsating. Then there is malposition. Malposition is not very important. Just remember, normally it should be occipital posterior is the most common malposition. Like let's say patient having cephalic presentation, then sometimes if the occipital posterior portion come to your pelvic examination, that's occipital posterior position. Let me show you a picture that becomes more easier for you to understand. So look at here. So that's the normal positioning. The vertex presentation you can see over here. But sometimes if the presentation is like that, so obviously that part is the occiput. Okay. Now, if you look at here, this is called occiput anterior. So occiput is anteriorly, that is normal. But now occiput is posterior to the pelvis, that is called occipital posterior. So this occipital posterior position is the most common malposition. Sometimes face can be presented, brow can be presented. So these are what we call as malpositioning. General rule in here is that if there is no evidence of cephalopelvic disproportion, no fetal or maternal distress, we will allow the labor to proceed. Aim for a vaginal delivery assisted by instrument if necessary, especially if it is the occipito-posterior or transverse position. But if it is a face presentation, then vaginal delivery is almost impossible. Cesarean section is necessary for that. Okay. So far, all good. Any question? So we have discussed about the antepartum hemorrhage, right? And antepartum hemorrhage means after 20 weeks of pregnancy, patient having bleeding. Now, what if the patient having bleeding in the early pregnancy? Bleeding in the early pregnancy is mainly what we call as miscarriage. So early pregnancy bleeding means the bleeding that happens in the first trimester. That means in the first 3 months of pregnancy. The most common cause of early pregnancy bleeding or miscarriage is the fetal chromosomal abnormality. Apart from that, there are some other causes like antiphospholipid syndrome, maternal infection. Okay, a lot of causes are there, but the chromosomal cause is the most common one. Now, if we go through these miscarriages, how they present. So most common is threatened miscarriage. Let me have a look. Threatened miscarriage means that if a patient coming to you, like a 10-week or 8 weeks pregnant patient coming to you with a parvaginal bleeding, but there is no abdominal pain. Okay, so that's most of the time threatened miscarriage present with just a parvaginal bleeding with no pain. Sometimes mild pain can be there, Then what you have to do, you have to do a vaginal examination. In the vaginal examination, if you see that os is closed, that's most likely what we will call it as a threatened miscarriage. And patient will also say that they haven't noticed any passage of any clot or any abnormal tissues with the blood. Okay, the management of threatened miscarriage is that you have to send the patient to the hospital for an ultrasound to confirm viability of the baby. If ultrasound is normal, there is nothing to worry about. Reassure the mother that it can happen in pregnancy, and most of the time, in 50% cases, it will have a normal, healthy pregnancy without any other problem. After threatened miscarriage, then there is incomplete miscarriage. Incomplete miscarriage causes more bleeding and more pain. So patient might present to you with a severe paravaginal bleeding with severe abdominal pain. Sometimes bleeding can be that heavy that patient can go into shock. If you do a vaginal examination, you sometimes even you can find that product of conception or fetal tissue is located in the opening of the cervical os. Okay, so that will confirm your diagnosis as well. And if you do that, you will also find that their os is open. So internal os will be open in here, and patient might say that yes, they have noticed some fetal tissue coming out. Now, if you see a product of conception in the internal os, then you have to remove that first. And maybe something more is there. So what you have to do, you have to do an urgent DNC to remove any product inside. Okay. So that's your incomplete miscarriage. After that, there is complete miscarriage, in which patient will have vaginal bleeding and uterine cramping, and it will lead all the product of conception coming out of the uterus. Patient will say, yes, they have noticed a lot of fetal tissue coming out or a lot of clots coming out, and their os will be closed. So in complete miscarriage, os is closed. You can only confirm it by doing an ultrasound that there is nothing in there. And management is just conservative. You don't need to do anything for this. Then there is missed miscarriage. Now, patient did not have any vaginal bleeding, no uterine cramping, nothing. But when you did the sonogram, you found a non-viable baby. That's what we call as missed miscarriage. In this patient, you have to go for either you can try conservative management with spontaneous abortion by induction of contraction by misoprostol, or sometimes, most of the time, we will go for a DNC in here. Inevitable miscarriage is not important for the exam. You don't need to remember it. So that's the most common form of miscarriage that is needed for your exam. Okay. Ectopic pregnancy, we have already discussed in gynae. So just remember all of those things. Give it a read as well. A lot of discussion is there about the management and everything. After that, then there is molar pregnancy. What is molar pregnancy? When the gestational sac is replaced by overgrowth of some trophoblastic tissue. That is what we call as molar pregnancy. Molar pregnancy patient presents to you with a bleeding in the early pregnancy. Along with that, they will tell you that they have noticed some passage of grape-like structures or some bubbles coming out. If you get grape-like structures or bubbles coming out with PV bleeding, we think about molar pregnancy. Molar pregnancy patient will have like very highly elevated beta HCG. And because of beta HCG very high, they will have exaggerated symptoms of pregnancy. So they will develop hyperemesis gravidera. So very severe amount of vomiting, nausea they will have. And also their uterus will be larger for dates. So these are all the features of molar pregnancy. So investigation, first you have to do the beta HCG level, that will be very high. And if you do an ultrasound, it will confirm the diagnosis. You will get a typical snowstorm appearance. Treatment is suction curettage with oxytocin. Now, because this patient, sometimes molar pregnancy can turn into choriocarcinoma. That means it can become cancerous, and even it can metastasize to the lungs. That's why this patient will need long-term follow-up, at least about a year. So the follow-up is important. We have to check their beta HCG weekly until it becomes 0, and then every month for 12 months. And we ask the patient to avoid pregnancy for these 12 months. If any time beta HCG gets abnormally high, you have to refer the patient for cytotoxic therapy like methotrexate. Okay, so that's all about your early pregnancy bleeding. Any questions so far? So we'll finish it here tonight. I think you guys have learned a lot. We will not discuss much more than this. We have a couple of other important things left. One of the important one, if you guys have Kaplan, not Kaplan, if you have JM 6th edition, then there is a chapter of maternal infection, which is very important for the exam. If you get some time, then read it, because you will have the next class after a week, I guess. So take that time to go through that maternal infection during pregnancy as well. Okay. Any question in our tonight class? No, it obstructed exam, prolonged, like obstructed labor, prolonged labor. I haven't seen this coming in exam that much. So not very important at the moment. But we'll discuss about the labor, that what is prolonged labor and what is obstructed labor and how we manage it. So that will be done in the labor class, in the next class. Okay. Misoprostol, you can go for parectal or oral. But most of the time in here, we go for DNC in early pregnancy miscarriages. All right, guys. So I guess everyone is fine with the class. No questions. We can stop the class here tonight. Thank you, everyone. We'll see you in the next class. Have a good night.